Well, welcome back to our introductory course in psychology, and we are in the last lecture of the lecture series, and we will discuss therapies, psychotherapies in particular, and what therapies are, and what do they do, and how do they do it. Uh, so, where did it come from, and what is psychotherapy to begin with? Psychotherapy will define as a psychological technique. Of course, that in and of itself it requires some definition in and of itself. Psychological technique used to facilitate positive changes in an individual's personality, behavior, and/or adjustment. Primitive treatments were marked by fear and superstitious belief in demons, witchcraft, and magic. There was so the first psychotherapeutic technique. Of course, they had the pretty much the right organ in mind, and that's the brain, or at least the head or skull. It was called trepanning or trefining in some cases, and this was a process by which they would bore, chip, or bash holes in somebody's head to relieve pressure and in most cases the last one, to release evil spirits. It's sort of like a hands-on exorcism, if you will. So treatments for mental illness in Europe during the Middle Ages really focused on demonology and concepts of religion. Demonology is the study of demons and people beset by spirits. Uh, Ergotism or ergo is a psychotic-like condition, and it's actually a fungus that is quite well associated with other psychedelics currently, but it is a psychotic-like condition caused by ergo poisoning or ergot poisoning, and it's easily mistaken for madness. People were possessed, and they needed an exorcism to be cured. So what is an exorcism? It is the practice of driving off an evil spirit, and it's still practiced today. In fact, I want to mention to you that even trepanning is practiced today. Now, not seriously, and certainly not by anybody in any kind of scientific orientation at all, but rather by individuals who believe that if some space is made for their brain, then that will relieve the pressure and allow their brain to expand to even become greater. Now, of course, that sounds like nonsense, and it is nonsense. I think some people have currently have done it for media attention in the same way that somebody claims that the Earth is flat. It's primarily just for media attention. But if you want to do your own research investigation, please be my guest and check these things out. So Philippe Pinel was a French physician who initiated humane, and okay, relative to then, yes, humane treatment of mental patients in 1793. So Philippe Pinel created the first mental hospital. Okay, now let's go back to our friend Sigmund Freud, who is really actually, he created psychoanalysis. He created the first form of what we all practice today in terms of psychotherapy, talk therapy. So psychoanalysis was the first real and true psychotherapy, and it was a little more than 100 years ago. In fact, a little more than 100 years ago, in fact, it was actually, a little more than 100 years ago. What did we have? Didn't have TVs, didn't have radios, didn't have telephone. No, yeah, we had some telephones, but they were few and far between. Electricity, yes, some lighting, that sort of thing. That's about it. And we certainly didn't have any of the modern means and technology to do analyses and diagnoses then. So we have to give him credit. He did what he could do in that period of time and where he was. He created the first psychotherapy, again, a little more than 100 years ago, to treat orders primarily hysteria, and mostly women presented with this disorder that he called hysteria. Today we call it conversion disorder. It's a somatic, it's a form of somatization where one believes that one's limb is without feeling at all. We'll get a little more into that. So hysteria is an outmoded term, and it describes people having physical symptoms like paralysis or numbness for which no physical causes exist. But like I just said, now it's known as a somatoform disorder, and there are various kinds of those. So Freud became convinced that neuroses, as he called them, and hysterias were caused by deeply hidden unconscious conflicts from the id. Remember that. We talked about personality and then personality development. The main goal of psychoanalysis is to reduce internal conflicts. Remember those conflicts between the id, ego, and superego, especially when the ego has to sort of protect the superego and the id from one another. So and the world also from the id. So it reduces. He believed that the reduction of internal conflicts led to better emotional stability. So the basic techniques of psychoanalysis, again, we're in the realm of talk therapy, was what he called free association. That is, say whatever comes to your mind. Now I know that a lot of us do that anyway, but that's not what Freud was talking about. Seeing whatever comes to your mind, regardless of how embarrassing or unimportant it may seem. Look on the internet, you'll find it all everywhere. By doing so, with lower defenses, unconscious material can emerge, Freud believed. See, the id really has no language to speak of. It just has desire. It just has pure libidinous energy. And so it really doesn't have a language. So the ego has to interpret the id for the outside world. So we can only speak it according to Freud, and everything I'm saying right now is according to Freudian psychoanalysis and theory, that the ego mediates, and because of this mediation, the fact that the id really doesn't have a language other than just pure libidinal drive, then what we see is in codes and symbols. And dreams were part of those codes and symbols, according to Freud and many others up to today. So Freud used free association and hypnosis and dream interpretation to gain insight into his client's unconscious mind. So some of the basic techniques of psychoanalysis. The first is dream therapy. Or dream analysis. In my going for my bachelor's degree, or second bachelor's degree in psychology, first course I took was in that I could take was in dream analysis. This is a fun course, and we were instructed to, as soon as we had a dream, to wake up, train ourselves to wake up with the dream, and then record it with the tape recorder there by the bedside, and then go back to sleep. And it was really quite an interesting process. And then we looked at these dreams from different perspectives, Freudian, Jungian, and so on. But according to Freud, dreams are the royal road. That's the way to get there. That's the superhighway, the internet with no traffic on it. The royal road to the unconscious, expressing in disguise code, forbidden desires, and unconscious feelings. All right, now how do we interpret that code? Well, let's learn some more terms. Manifest content is the obvious visible meaning of the dream. All right, so if you're falling, yep, you're falling. Latent content is the hidden symbolic meaning of dreams. For example, if you're dreaming you're falling, yes, the manifest content is you're falling, but the latent content may be an expression of losing control and panicking from that. So dream symbols are images in dreams that have personal or emotional meanings, and they differ from literal meanings, right? It's code. They're symbolic, like a snake or a train or sword. In dream technology, and he often thought about sexual dream coding or symbolism hidden within dream content. So, for example, he considered a snake or a train or sword as a penis symbol and a tunnel or a cupboard or even a ship, the vessel of a ship, as a vagina. So, under free association, his techniques, this is a patient, just talk about anything you want. Here's one of the problems that you had to get through, and that was the patient's resistance. And that is, you're laying there and you're laying on the couch, and this is the old symbol. You see the therapist sitting behind the patient, and the patient laying on the sofa, therapy couch. Now, what do you talk about? Now, in Freudian analysis or even in Jungian analysis, if you don't have anything to say, the therapist probably isn't going to say anything either, depending upon the context of therapy situation and how they're trained. But generally, you have to get somehow through that resistance. And this occurs when the patient becomes reluctant to talk about a certain topic, or changing the subject, or even becoming silent. Even this in itself could be interpreted and switched around according to Freud. Transference, and here's a great concept, both transference and countertransference. So in psychoanalysis, transference is the tendency for a patient or client to project positive or negative feelings for important people from the past or present onto the therapist, whereas countertransference, the therapist projects feelings from his or her own relationships onto the patient. So in psychoanalysis today, look, we don't basic Freudian psychoanalysis can take years. Take a look at one of the funniest trips I've seen on psychoanalysis is a movie with Bill Murray in it called What About Bob? And in that, Richard Dreyfuss is the psychoanalyst. And they're just sort of poking fun at psychoanalysis there in a way. And even a big Buster Freud comes flying out of a house that is exploding and lands at their feet smoking. So at any rate, so today we have brief psychodynamic therapy. We don't even call it analysis anymore because there's nothing to analyze. It's based on psychoanalytic theory, but it's designed to produce insights more quickly, under the assumption that an insight changes behavior. We need to talk about that big assumption right there, and uses direct questioning to reveal so-called unconscious conflict. Interpersonal psychotherapy, which is another form of it's just an updated form of psychoanalysis, is a brief dynamic psychotherapy designed to help people by improving their relationships with other people. That sure makes a lot of sense. Seriously, it does. And spontaneous remission is an improvement of psychological condition due to time passing without any therapy. Or perhaps they didn't need therapy to begin with. Some do, some don't. That's another question. Do you really need therapy? Can you just sit it out? So what are some of the dimensions of psychotherapy? First of all, insight versus action. So do you know the cause of that, if in fact that is findable, explorable, and discoverable? Do you know? So the goal of therapy is for clients to gain a deeper understanding of thoughts, emotions, and behaviors. So does that change behavior? Does that change or make the client feel better? And it does. I have found personally with clients, it does. It helps then, and in all the therapy I've been in, it also helps for about an hour after therapy, where I've gained it, and I go, oh, that's right, that's the reason, and then it's still the same thing. So insight, okay. Action is the goal of therapy is to bring about direct changes in troublesome thoughts, habits, and feelings or behavior without seeking insight into their origins. How about let's help our client feel better. Reduce that client's distress, because that is very painful. Let's just do that. Okay, next point is directive versus non-directive. Directive is you give guidance, you give advice, you say, hey, do this, hey, try this, da, 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 da. Non-directive is the therapist you assist, you reflect, you try to maybe clarify, but you don't actually get in there and provide any kind of direction or any intrusion whatsoever. And believe me, those two, that dimension right there, directive versus non-directive, that is one of the, in therapy training, when we try to train therapists, that's one of the most important dimensions to moderate, because you can send somebody out of your office, or somebody won't come back if you attempt to direct a highly reactant individual, somebody who has a lot of autonomy and opposition. Then there's individual versus group therapy, and of course, I think we all know about that. And they both have advantages. So individual therapies, you walk in, you talk to your therapist for 40, 50 minutes. It's usually not a full hour. And in the other, there's a group. Then that group can be as small as two or three others, or quite large, maybe a room of 20 or 30. And at some point, it stops being that; it becomes sort of a workshop or self-help group. Then there's, of course, group therapy. Several clients are in that. Now, then there's also open-ended versus time-limited. Now, open-ended therapy is also the classic garden variety Freudian therapy, non-evolved Freudian therapy. And so it's got an unlimited amount of time. And as I said, people have gone to Freud, still do go to Freudian psychoanalysts for years and years and years. It's no time frame, and it could involve 3 sessions a week and over many, many, many years. So there's no real measured outcome per se. It's just like the client says, yeah, I feel better this week, and the therapist says, oh yeah, sure, you feel better. However, there's not a standard frame of reference of what's being worked on, what the goal is. A time-limited therapy is a therapy, and we talked about that. It's begun with the expectation that it'll last only a limited number of sessions. A lot of employee assistance EAP programs have these types of time-limited therapy programs woven into their EAP. Okay, so what do we put the emphasis on? It's so it's insight. Now remember, you need to learn these things when you're becoming a therapist, and practice them as well. And you need to be able to moderate across all of these dimensions. You should be able to. Now, do a lot of therapists? I'll leave that for you to decide. Insight versus action, directive versus vocative, systemic versus client-centered, group versus individual, short versus long-term, planned versus spontaneous, and with versus without homework. That's a big deal also, and it's really important in cognitive therapy and cognitive behavioral therapy. So what are some myths about psychotherapy, among which there are many myths that really cause some very unfortunate stigmas in our culture? But here, psychotherapy is not equally effective for all problems, and that's a myth. That's true. It's not equally, as is anything, is not equally effective as all problems. In fact, a particular therapy is not even effective given, let's say, 30 clients walk into are lined up at a therapist's door, and they all have basically the same level of depression as measured by the Beck Depression Inventory. And this therapist practices the same therapeutic procedure to all of them. Will they all improve at the same rate? And then at the end of 10 weeks, we measure them, and they'll be at the same depression, or about the same depression level, and show a decline from the rate at which they were when they first entered the therapist's office. No, they won't, because the therapies need to be matched to the individual also. In the same way that not all procedures, a single medical procedure doesn't fix all problems for anything. You have to match the procedure with the problem and the individual with the problem. So more complex problems are very difficult to solve, and extreme cases, they don't respond to psychotherapy. They may have to respond to medical therapy, drug therapy, or even in an environment, in a restrictive environment, or in hospital in therapy. So psychotherapy is not necessarily a major overhaul of the psyche. It could be supportive or positive, and that's true. It's supportive. Therapist's goals are to offer support, not to promote personal changes. A therapist's goal is not to make you better or worse, because there's no such thing. There's no value there. The idea of better or worse, that's a value scale. You run into a therapist that does that walk. It's don't go for value scales. It's not an overhaul of your psyche. Don't walk in there thinking, oh boy, I'm going to get me a major tune-up, because it's not going to happen. The therapies are designed to enhance personal strength and not to fix your weaknesses. Perhaps find a coach to do that. Let's talk about some of the different types of therapeutic domains, different types of the way in which people are coached, let's say, through their issues and challenges. And this is really the therapist's job. So the humanistic therapies are insight therapies, just similar to the Freudian therapies, but they're much more. They're not looking for clues of the evil id trying to affect us in malicious ways. So instead, they're insight therapies intended to help clients gain deeper insight into their thoughts, emotions, and behavior. In other words, to get insight in another manner. So that, in contrast, cognitive therapies or action therapies less concerned with insight and rather with just helping people change in harmful thinking patterns. Or in other words, does it make a difference if you know what caused you to do whatever you did that you don't like? You're what we call ego dystonic about. What really matters is that you don't do that anymore. Now, if you are able to resolve that with yourself, great. But the main thing is, we don't want you to be bothered or conflicted about that anymore, because if you do it again and again and again, a couple of things are going to happen. You're going to feel worse and worse and worse. That's problematic. Or you may acclimate to the bad behavior and start to acclimating to it. You might want to have worse behaviors because you've acclimated already to the first. That sets up a problem, perhaps of addiction, or some very similar serious criminal behaviors. So the idea here now is stop that. Whatever that is that you don't do it. Now we can talk about what you don't like or like about it and where it came from some other time. But right now, just stop. So the humanistic therapies believe that humans have a natural urge to seek health and self-growth. Remember Abraham Maslow and Carl Rogers? So yeah, self-growth, that it's possible for people to use the potentials fully and live rich, rewarding lives. Now, I think that, this is my opinion, I think that therapies must be globally applicable. I think that we need to be able to extend and generalize therapy. So I'm wondering how this therapy applies to all cultures globally around the world. How would you apply this and live a rich, rewarding life? I would love to apply this everywhere. So Freud claimed that patients could expect only to change their hysterical misery into common unhappiness. So there's four conditions, and this comes from Carl Rogers, and this is something that every therapist, every a psychotherapist, every psychiatrist, or psychologist, or social worker, or marriage and family counselor, we all have to learn: unconditional positive regard, empathy, and authenticity, sometimes called genuineness. Or in other words, we need to convey this unshakable, unqualified acceptance of another person. And in fact, we're told that if you can't do that with somebody, to please refer them. And so usually some of the worst cases, what if you're presented with with a child murderer? This can you? So no, I have to refer them out. Empathy is one's ability to feel what another person is feeling. Sometimes that's difficult. Sometimes a lot of people think, but that's sympathy. That's listening to something and then saying, "Oh yeah, that's pretty bad." And the empathy is a deeper, not just a feeling. It's a comprehension. It's a capacity to take another person's point of view, and it's not just standing in their shoes either. It's very important in therapy, and it is what burns a lot of people out, because if you do that too much, you're just going to burn yourself out. Then there's genuineness or authenticity, and that is that we're able to be genuine and honest about our feelings and our thoughts. I want to explain something to you that I try to explain to graduate students. So you're going to get this now rather than a graduate student, because it seems to be an eye opener to everybody who hears it. Therapists, we are practiced manipulators. We're beneficial manipulators, but we're manipulators nevertheless. We want to manipulate you to do and think the things that will help you to feel better. This is without any value or anything like that. But it is a manipulation. And this manipulation sometimes can be quite subtle to move you in the direction of feeling better, because a lot of people don't like to even feel better. They'll resist you. Reflection is our ability to rephrase or repeat thoughts and feelings. We have to listen to you. And listening, even in and of itself, is a skill that we have to develop and learn. There's some things about listening that we actually have to learn. Then there's something called existential therapy. So this is an insight therapy as well, but it focuses on problems of existence like meaning, choice, death, responsibility, and it emphasizes making difficult choices in life. Some people, in fact, are stuck in what we call an existential reality, or in other words, they're quite depressed because they believe that no matter what is done, no matter what they do, it's going to turn out the same anyway, and then they're going to die, and then that's it. Free will, and you've all heard about free will, is one's human ability to make choices. And in other words, you can choose to become the person you want to be. Confrontation. Clients are challenged to examine their values and their choices. This form of confrontation, I'm not sure about its usefulness. Obviously, the people who practice existential therapy believe that confrontation is very important. What we find important is a form of therapy that is a cognitive form of therapy for depression. We'll talk about it later, but it's called rational emotive, or RET therapy, rational emotive therapy, where individuals who are depressed, when people are depressed, they have irrational thinking. And so the therapist confrontationally challenges those thoughts. And in that sense, confrontation can be very important. Other times, confrontation can be damaging, certainly to the point where your client doesn't come back to see you anymore. There's something called logotherapy. This is developed by Viktor Frankl. Logotherapy is also a form of existential therapy. It emphasizes the need to maintain meaning in one's life, and meaning to us, to us, there humans, is very important. Gestalt therapy it was developed by a therapist. His name is Fritz Perls. Fritz Perls was very popular back in the 50s and 60s. He spent a lot of time at the Esalen Institute up in Big Sur in California, on coastal California. But this is a form of humanistic therapy, and it focuses on immediate experience and awareness to help clients rebuild thinking, feeling, acting into connected wholes. This graphic I have there on the left is called two-chair work, where you are imagining talking with somebody who's not there, obviously, is gone. So that may be a parent who's not there, or a spouse, or a sibling, or somebody who isn't there, and you talk with them. It is a therapy that can actually partially cognitive, but nevertheless, if your client can do this, it's a recommended way to do it, except that to some degree, if you do it too well, it has to be modulated because your client can't just explode in anger or anguish or something if they've imagined that other individual too well. Okay, cognitive therapy, and this is sort of more on my turf, is a therapy that helps clients change thinking patterns that lead to problematic behaviors or emotions. Here's the cognitive therapist. I'm basically cognitive behavioral therapist, in that we believe that cognition, a thought, is in itself a behavior. And it is. There's energy expended. There's work. When you think of something, there's neurotransmitters and therefore action potentials that move around in neurons. Not a few of them, perhaps billions, trillions of them for any given thought. There's action. There's behavior there, and that's a thought. Thoughts cause feelings. It's not the other way around. Therapy helps clients to change patterns that lead to problematic behaviors or emotions. Cognitive therapy is successfully used for many problems ranging from generalized anxiety disorder, that's a difficult disorder, by the way, and post-traumatic stress disorder, another one, to marital distress and anger. Yeah, wow. Those are difficult things to deal with as a therapist, as a patient too. Cognitive therapy has been especially successful in treating depression. So cognitive therapy for depression was developed, the spearhead for it, his name is Aaron Beck. He was a psychiatrist. But down here, the developers of the initial cognitive therapy for depression, which has been very successful as a therapeutic technique for depression, aside from the drugs, the antidepressive drugs that are used for depression, and it was developed by Beck, Rush, Shaw, and Emery. So in the cognitive therapy for depression, we focus on your thinking. What are your self-defeating thoughts that underlie your depression that you aren't even aware of? You can say, what are your self-defeating thoughts? I don't have any self-defeating. Yes, okay, what are they? Because they do exist, you're just not aware of them happening. And they're not coming from the id. Remember, the id doesn't have any language. Selective perception, perceiving only certain stimuli in a larger group of possibilities, like saying, I'm such a failure, I'm such a failure. Now, you're on one or two, on a line of things that you may have tried, but there's a whole host of other things that you've done and tried in which you were a success. But when we have selective perception, that's what happens. Then there's overgeneralization, which allows an upsetting effect or event, that is, to affect unrelated situations. There's all or nothing thinking. Everything has to be all good, all bad. It's either completely perfect or it's terrible. There's a list of other basic forms of negative thinking that are indigenous almost to depression. Then I mentioned this earlier about confrontation, rational emotive behavior therapy, and that's Albert Ellis. Rational emotive therapy, or RBTT, or RET as I call it, rational emotive therapy, attempts to change your rational beliefs that cause emotional problems. So you've got some activating experience, and it results in a belief, which results in a consequence. So people and things do not upset us. Rather, we upset ourselves by believing that they can upset us. So somebody's saying no one can really. There's some activating event which then is processed in one's brain. Thoughts and beliefs, they get all churned together, and then there's consequences, and those consequences depend upon what the individual has available as output. Many times it's just I'm going to feel bad about that. So there's these tracks that we try to help people to disengage themselves from, so that this ABC process doesn't occur, or at least occurs less. There are three core irrational beliefs, however. I have to perform well and be approved by everybody. And that says significant others, but I mean everybody. Or in other words, if the attendant, if the clerk at the grocery store frowns at you, that'll ruin your day. So not just significant others, everybody. You must treat me fairly. When you don't, it is horrible and I can't bear it. That's the second one. Third one, conditions must be the way I want them to be. It's terrible when they're not. And I can't stand living in such an awful world. Now, those are the three core irrational beliefs, and they manifest themselves as groups in the thinking of one who is depressed. Believe me, I've seen it many, many, many times. And if you are depressed, if you do a little self-examination, you'll find that in yourself. So we could talk about all kinds of cognitive distortions for almost any addiction. Now, I've got one up here for gambling, and so these are just cognitive distortions of this for a gambling addict. Magnified skill, different attribution errors, gambler's fallacy, and selective memory. The gambler also overinterprets the cues and puts much more faith in irrelevant things, body sensations and feelings that obviously he wants them relevant to what's going on, but they're not. Or luck, simply luck as a trait. The gambler believes that he or she is lucky, or the person in general. Also, there's probability biases, and makes incorrect beliefs about randomness and chance events. So there's no winning. So straight behavior therapy. What is just straight on behavior therapy? And in fact, what is that? There's some method by which a behavior is changed, obviously. But then again, isn't that the point of all therapy, to change behavior? This, however, acts directly on behavior through the learning theories that we learned earlier, specifically conditioned learning and operant learning. So what is this? Is an action therapy, and it uses the learning principles to make constructive, one hopes, although we can make the destructive change. That's how the destructive changes came about, are also through accidental applications of these learning principles. So the therapy attempts to, in a way, to reverse that, or at least to ameliorate it or eliminate it. So what is it? So the behavior therapist assumes that people have learned in the same way they are, the way they are, and can change by unlearning more appropriate behaviors. Now, it is in fact that we learn from all different types of media, or in other words, I think most of us have never encountered, let's just say we've never really had, I'm talking about a negative interaction, like been bitten by or strangled by or anything like that, let's say a snake. If you had never heard anything negative at all in your entire life about snakes, would you be afraid of it, or a spider, or any of the other small, basic stimuli that we consciously and unconsciously learn very, very early from other people's reactions, is how we learn it. And if other people react violently to a certain stimuli, then we pick that up. Now we pick that up through observation. We pick and so we've picked that up, and it has become what we've learned. It's become an emotional memory. So the vision of it, the object itself, and when we see it, it's emotional. If we continue to avoid that now, that actually is called negative reinforcement. So now we reinforce our fear of that stimuli by simply maintaining a distance from it, further and further and further. So, so uh, insight isn't necessary for this kind. You don't have to understand. Hey, you really not to be. That's really dumb to be scared of that snake. It's just a little harmless, or that spider, or whatever. Yeah, yeah. There's poisonous spiders. There's poisonous snakes. Hey, you drive in a vehicle that is truly any vehicle that is I mean, that's so fatal, that's so dangerous. A car is far more dangerous than a snake, but do it every day, sometimes for hours. So it's not just that, hey, that's some of those snakes are poisonous. No, it's something else. What is behavior modification? It is applied, in a way, applied behavior analysis, and it uses classical or operant conditioning principles, as I just said, to directly change our behavior. Aversion therapy is actually, in a way, a form of behavior therapy. I've got this little graphic here of in A Clockwork Orange. I had mentioned A Clockwork Orange, I think, in other lectures. But here, the protagonist in A Clockwork Orange, they're attempting to cure, quote unquote, cure him of his violent behavior. And so he has his eyes open, and he's wired, and the quote unquote the scientists are in an auditorium with him, and they're showing him lots and lots and lots of film clips of all different types of violence, and he's forced to watch this. Now, while he's watching this, as he has these violent urges, internal urges from watching these films, he has also been given, injected an emetic. Now, an emetic is something that makes you throw up, vomit violently. So he's getting an aversion therapy to violent images, because he worshipped before he was caught. Now he's of course caught, but they're trying this therapy on him. He literally worshipped violence. So it is aversion therapy it associates a strong aversion. In this case, the aversion is to throw up to an undesirable habit: smoking, eating, drinking, alcohol. So I got to tell you something. Some of these don't, most of them don't really work. There was a chain of hospitals that were called Raleigh Hills back in the 70s that attempted to use the aversion therapy, again using emetics like the one I just mentioned, along with some other social cognition problems. For example, they put you in a barroom setting or something, and basically you'd sit there as if you were sitting in your favorite bar, and then they inject you with an emetic, and you'd sit there and drink your favorite drinks, and then you'd become deathly ill. And you do this over and over and over, and eventually you know what you want to see. And the thing is, it becomes very, very, eventually it doesn't really generalize as well as we would like. Instead, it becomes very specific. Well, I don't want to drink in that hospital anymore is basically what it comes down to, if you think about it. So aversion therapy, I just mentioned this for drinking, and this was developed by Roger Vogler. This receive a painful electric shock to the hand when beginning to take a drink. It also, like I said, is a emetic. In fact, emetics are still used for drinking. It's called Antabuse. It's an emetic, and if you take Antabuse and then have a drink of alcohol, you become violently sick because your liver. It disables your one's liver from metabolizing alcohol only. It removes the one of the primary enzymes responsible for that metabolism. So you become very, very sick simply with the aldehyde concentrations moving up in your body, and really, really throw up. Desensitization is another form of behavior therapy. And in systematic desensitization, we use guided reduction in fear and anxiety. I've got also about a spider, a photo of a spider, and it moves up. Like I said, I do this with in VR with people with very simple phobias, with spiders and snakes, acrophobia, bees, um, sharks in the water. But as we become more complex, for example, with post-traumatic stress disorder, there's much more involved in that context of fear because it involves more sights, more sounds, more feelings. Uh, Check out Skip, S-K-I-P, Skip Rizzo, R-I-Z-Z-O, Skip Rizzo, and his laboratory, his virtual reality laboratory at University of Southern California. You can YouTube it. He's got lots of stuff on there. Lots of good stuff he's doing in VR with post-traumatic stress disorder as well. But in that, that really wasn't a tangent. That was to bring us back to systematic desensitization. That's what he uses, but in this higher technological realm. There's vicarious desensitization. Gee, I wish I had graded to get to this page. And that is indeed what we see in that is vicarious desensitization and virtual reality exposure. It is really coming of age and will be even more and more and more important in the next 10 years. Eye movement desensitization and reprocessing was developed by Francine Shapiro. EMDR is something that is also really rapidly expanded within the last 20 years, 30 years or so. I have just YouTube EMDR, and you'll find a lot of eye movement desensitization and reprocessing literature on there. I also strongly suggest, that you research not just Google and YouTube, but also try going to PsycInfo, Psych articles, perhaps even PubMed, and look at some of the research done with EMDR and its effectiveness, and also the comparison to other treatments for depression and for post-traumatic stress disorder. Operant conditions, like principles I said that we use, behavior therapists use, positive reinforcement and non-reinforcement or extinction is really important. Punishment, not so much punishment. Look, a no response, a silence is punishment. Shaping, stimulus control, timeouts. So when we apply non-reinforcement and extinction, this is really one of the most frequently occurring human behaviors, and they usually lead to some form of reward. An undesirable response, it could be eliminated by desiring and removing the rewards that maintain it. What do we do if there's not some sort of payoff? Now, the payoff is not necessarily money. It can be an adrenaline rush. I mean, look, why do some people like pain? Well, because it produces adrenaline rushes. It's not necessarily something positive. Why is some children, why do they repeatedly do something that nobody else wants? It's to get attention. And what is that attention? It gives them a rush. So a rush is a good thing to a lot of people. Food, money, they're obvious rewards, but attention, approval, concern, they're powerful reinforcers. Token economies are useful. Hey, we live in a token economy. We set up token economies in hospitals, in our behavioral health hospitals. But face it, the globe is essentially, this is a token economy. It is a symbolic reward, a polka chip, a gold star, and this can be exchanged for real rewards. And this, of course, reinforces positive. This is a positive reinforcement, same way as a paycheck is. But like I said earlier, it's really effective in psychiatric hospitals and our sheltered care facilities. Reinforcement and token economies. as I mentioned, in psychiatric hospitals, we get tokens like a socially desirable or productive behavior. So if you don't try to steal the other patient's newspaper or something, then or don't disrupt their checkers game and stay cool, you'll get tokens for that day. The most effective token economies are those that gradually switch from tokens to social reward, though, like praise and recognition and approval. There are, of course, medical therapies. Medical therapies work. Major medical disorders are more treated medically. I can tell you for a fact, because I worked in wards with patients with schizophrenia for a long time. Also worked in a program where we had to first titrate all the patients off the medications they were on, so that we could then do a double-blind study with the new medication. And depression, many people use Lexapro, Prozac, which is an older selective serotonin reuptake inhibitor, and a lot of others. So there's a lot to be said for medical therapies, a lot to be said. The graph that you see on the right is something that I did personally. Just simply, I pulled data from a server for an insurance company I had consulted for, and I developed this outcomes program for them. And in this outcomes program, I got on this in the server and looked at patients who got drugs only. So they only went to a psychiatrist a couple times only to get a prescription. Then you see therapists only, and these are individuals who got no prescription, no psychiatrist, but they went only for psychological sessions. Then the third column over there, therapist and drug, these patients got both the psychological sessions as well as some sort of drug therapy, usually SSRIs. And the fourth was something I was particularly interested in. Those were people who changed therapists over a period of 1 year, 3 or more times. I won't talk about the fourth one. It applies to something else. But you see drug only, therapist only, drug and therapist. And you can see that the therapist and drug is the highest level it is. Now, this just simply replicates probably 100 other studies you can find on the replicable databases that show the same thing, that the best way to go for the treatment of depression is both therapist and drug. Therapist only works, drug only, it works, but not as well as the two combined. Drug therapies include both the antipsychotics, which I discussed for the treatment of schizophrenia, as well as for the bipolar disorders. I'm not going to go into the discussion of you can go back and look at what the disorders are. Then there are stimulants. We all have some stimulants anyway. Then there are the depressants and the hallucinogens. Pharmacotherapy is the use of drugs to treat psychopathology. Anxiolytics are drugs that produce relaxation effects that reduce anxiety, like Valium or lorazepam. Antidepressants are drugs that elevate mood and combat depression. Now, I really need to, one would have to talk about elevating mood. I think antidepressants really do more is that they simply allow that bottom to float up, because it really shouldn't be there to begin with. It's just all of that selective thinking that just needs to float off so that the bottom floats back up to a more normal level. Whether they elevate mood, I mean, yeah, in that sense, the mood is elevated and the bottom is raised. Elevating mood, however, one can do with like an amphetamine, but then that's yet another issue. But they do, in fact, elevate mood as the bottom is raised. So the Prozac does that, Zoloft does that, and Lexapro does that, and some of the others. Antipsychotics tranquilize, and they also reduce hallucinations or some of the active, so-called active components of schizophrenia, and that is they reduce hallucinations and delusions and so on. Haldol, Thorazine. I mentioned that I was part of the team here to to do the clinical trials for a drug called risperidone. So we actually had to titrate to remove the Haldol and Thorazine, the different drug regimes that the different patients were on in our ward to baseline, so that we then could do this double-blind study with the risperidone as well. So what are the limitations of drug studies? Because as you could see back here, the drug only, over the long term, that really didn't work quite well. Now, so the limitations are, regardless of benefits, there's risks. So let's look at clozapine. And clozapine relieves schizophrenic symptoms. But that's 2%, 2 out of 100 patients may suffer from a potentially fatal white blood cell disease, okay? 2%. Oh, yeah, it really. So 2 out of 10 patients may suffer from a potential fatal white blood cell disease. That 2%, you wouldn't get on an airplane and 2% of the airplanes go down in a ball of flames. So 2% is a big number, as well as some of the other issues. Now, I should say that, hey, we want to relieve you of your schizophrenic symptoms, so we're going to give you this drug. No, because there are some methods by which the individual may or may not be prone to that white blood cell disease. ECT, or electrical stimulation therapy, or electroconvulsive therapy, as it's really called, is passed through the brain. It produces convulsions. It also does things to the memory. Now, Hollywood has unfairly depicted ECT. It is not bad. It's not somebody shaking all over the table and defecating on themselves. It's not that at all. It's a very calm procedure, and it works, especially with somebody who is seriously, chronically, and profoundly depressed. So supporters of ECT, it does. It doesn't. So there's a URL there for ECT. Please, if you like, look that up also on YouTube. And there's other ECT treatments that you can watch, but they're done in a medical setting. The individual is relaxed and also has a muscle relaxant. They don't vibrate and shake all over the place. In fact, they don't even feel it. So please, I give you, please take a look at that. It does produce a temporary improvement, but look, if you're aching the way an individual that really needs ECT is aching, then that's fine. Temporary is okay. It can cause memory loss. With some patients, that is a good thing. Only after other treatments have failed. That's true. It should be used only after other treatments have failed. And to follow the chance of relapse, ECT, okay, it's almost always followed by antidepressant drugs. Implanted electrodes now is something if those who don't really benefit from drug therapy, ECT improvement, specific drug regions such as brain pleasure centers are stimulated and can be used to treat disorders other than depression, like obsessive compulsive disorders. Now, I really haven't seen this. I think it's an okay idea if it can be perfected to the point of zero risk. There's really no zero risk, but at least a 0.00001 risk. Obviously, the psychosurgery, we've all heard of brain surgeries, but now that's for tumors and what have you. But what about psychosurgery? It says this is a surgical alteration of the brain, and it's designed to bring about a desired behavioral or emotional change, not the spread of a cancer, but again, a behavioral or emotional change instead. Now, you start to operate on somebody's brain in order to make a behavioral change, especially if it's based upon some evaluation. You need to think about that a few times. And so there was something called the lobotomy. I suggest, look, it upsets me if I talk about it too much, but it was performed to control aggressive, violent, undesirable behaviors, not just of prison inmates, but of women. Because they didn't obey their husbands correctly, or something like that. I advise you to please look up the prefrontal lobotomy. The man who invented the office prefrontal lobotomy, please believe it, won a Nobel Prize in medicine. Mental hospitalization has come a long way. You'll notice there the beds, and you'll notice next to that it's the bell tower of what used to be Camarillo State Mental Hospital. Now, I did intern at Camarillo State Hospital, and in fact, I just had a book published about a month ago up here. It's called Insanity. You can see there the little Camarillo Mental State Hospital tower there. The book is called Insanity. It's a good read. I suggest you pick it up, but it examines schizophrenia, not completely like how to. This is a book of fiction. Okay, so don't expect profound insight in curing schizophrenia. It's a book of fiction. You might gain insight in some other area, but that's up to you. The Sandfly looks at voyeurism and OCD, obsessive compulsive disorder, but it also looks at societal and cultural maladies and anthology. I have a story in there called David Wakes Up, and that examines alcoholism. Deinstitutionalization is the reduced use of full-time commitment to mental institutions. We're getting more and more into that. In fact, too much, because in fact, what we usually have is what you see there in the middle of the 2000s, living inside the box. Deinstitutionalization is essentially what we've got. So we still have to plan that will save even more money. So we'll take them out of the state mental hospitals, here are the patients, and we'll put them in a jail, homeless shelters, private hospitals. Oh boy, that costs money. Invest in that. Nursing homes, and of course, dumpsters. That's where deinstitutionalization has pretty much got us. Community mental health centers, again, they're great. They offer a lot of health services, prevention, education, therapy, crisis intervention. There's crisis. We get skill management of psychological emergencies, and again, crises. So within this, then now we also get the influx of paraprofessionals, and these are persons who work in near professional capacities. Are psychotherapies effective? Now, look, I could go into I could tell you a long evolution of the studies and methodologies looking at the effectiveness of psychotherapy. So I just will summarize it in this. The studies show that there are positive effects of psychotherapy counseling, positive meaning a change of negative symptoms to more positive or less negative symptoms. So there's a positive effect for psychotherapy counseling and other psychological treatments. People receiving therapy are compared to a waiting list or control group of people. This is done many times now, not just once, who are waiting to receive therapy or doing something else other than getting therapy, like reading a book or something. And people receiving therapy improve no more than the people receiving the therapy or people that did not cause change as a placebo. So we see that people do improve with psychotherapy. They do improve, but the improvement is really a view just only if you look at the improvement, the overall improvement of individuals over time, about 10% of that, only 10%, is based upon whatever the diagnosis is, whether it was depression, anxiety, or whatever, alcoholism. The rest of it is due interpersonal characteristics. So those people who are master therapists, who are good therapists, are learners, and they draw on their experience, and they themselves, that individual themselves, is mentally healthy and mature, and cultivate a working alliance. When we have good basic counseling skills, we are good at acting, listening, reflecting thoughts, silence when need be, and we design our questions. Remember, I told you we're manipulators. So these questions are designed, if it's open-ended or closed-ended, that's by design. What are some of the basic counseling skills? We clarify the problem and focus on feelings. Avoid giving advice unless, of course, you're dealing with a somewhat of a docile individual who wants the device, who wants the advice. To some degree, you give it to them, not completely. You also want to cultivate active decision making. Accept the client's frame of reference. Okay, unconditional positive regard. Remember that. And it's just a simple part of a basic ethical contract that we make. Maintain confidentiality. There are lots of new medical therapies that I suggest you delve into as well. Transcranial magnetic stimulation. There are group therapies, a lot of them that we discussed already. Oh, there's psychodrama, which is an interesting form of psychotherapy, role playing and role reversal and mirror technique. There's family and couples therapy. We already talked about the different types of that group therapy. Well, within group therapy, there's family therapy, couples therapy, other types of therapy. These are the two major types of group therapies, both family and couples. There's group awareness training, sensitivity training, encounter groups, large group awareness. Now, these really kind of move out of the realm of therapy and really more into the realm of encounter group, work group, self-management, and seeking professional help. When do you decide or even think? Now, it's not somebody that tells you, "Hey, you're crazy. Go see a therapist." No, I'm talking about you. When you believe to yourself that your level of psychological discomfort, pain. So, what is that? It's unhappiness, it's anxiety, it's depression, and it's discomfort. It's comparable to physical discomfort. You go see a doctor. Okay, so now think about at this point seeing a psychologist or a psychiatrist. And when you make the decision, I am uncomfortable, I need to get help, that's a good thing. If you were uncomfortable physically with something that pained you, you'd go and get help. I don't like this. Please do it for your mind. Another signal to watch for are the quality of your work, like your career work, your school work, or your rate of absenteeism. It could be, due to an addiction you're following. Relationships start to wane off. Or let's say that you've had urged a friend to seek professional help, and you're dismayed because she or he refused to do so. Mind your own business. If you find that friends or relatives are making a similar suggestion to you, you need to recognize that they may be seeing the same things that you thought you're seeing in the friend you told to go get help, and that friend dissed you. Okay, now you're dissing somebody else, and they see the same problem in you that you saw in your friend. It's an eye-opener. If you have persistent or disturbing suicidal thoughts or impulses, look, no one thinks about wanting to die unless there's a problem. Seek help. Now, how do you look for a therapist? It's a shot in the dark, folks. Right now, it's a shot in the dark. Colleges and universities, workplaces, communities, mental health associations, hotlines, Google. Okay, I had Yellow Pages. I took that out of there because there's no such thing as Yellow Pages, but they were used to be in Yellow Pages. Now, remember I said that only about 10% of diagnosis it reflects outcome, and that's true. Now, when you find some therapist, or what do you ask them? Because if you, let's say you're depressed, you call the therapist and you say, hey, do you handle depression? Sure, I do. I handle depression. In fact, you can go to their website. They handle everything from depression to standing on your head too long, and you need to make some decisions. What do you ask? Will the information I reveal in therapy remain confidential? Okay, one. It's obvious. What risks do I face? How long do you expect me to be this? To be in therapy? What form of treatment do you expect to use? And they'll say something like, well, I have to see you first. I can't tell you. Are there alternatives to therapy that might help much more? That's a fair question. Listen, once you go see a therapist, and I put this number one, your therapist never makes any kind of, not just a sexual advance. I mean, that's the most profound. Not even a personal advance. Not even a, hey, let's go to lunch sometime. Or no advances. No personal advances. Any kind of verbal, a threat. Obviously, it's terrible. It's hostile. Or a therapist who talks about his or her own problems, dependence. That demands absolute trust or tells you not to discuss therapy with anybody else. These are dangerous that make almost anybody you'd bristle with a person, not a non-therapist. Okay, the therapist. So bristle even more if you get any of these signals. Okay, don't. Now that's the end of the discussion for therapies. I am also going to suggest that you check out what I suggested before, and something that might help you out and fill in the rest of that 90%, because the 10% is only the diagnosis. Check out Inner Life, INNERLIFE.com, innerlife.com. And it is a site that Dr. Larry Butler and myself and Dr. Bruce Conger and Dr. Karen Friday, we all developed the system, and check it out. You might find some solace or insight in that, and I suggest you contact the runner of the site. His name is Dennis Heller. He is now the Chief Executive Officer and Chief Financial Officer. It does a very good job. Contact him, and he will be able to set you up with what you need. So thank you very much for listening. Goodbye.